Hi, I'm Jim Smyrniotopoulos, and we're going to be discussing intraaxial neoplasms. Most gliomas are diffusely infiltrating masses. They can be arising from astrocytes, oligodendrocytes, and also include glioblastoma multiforme. However, some gliomas are circumscribed. Pilocytic astrocytoma, subependymal giant cell astrocytomas, which occur in tuberous sclerosis, the unpronounceable pleomorphic xanthoastrocytoma, the mixed glial neuronal tumor Ganglioglioma, and both ependymal and choroid plexus tumors are well circumscribed within the ventricular lumen. The fundamental difference between a circumscribed astrocytoma and a diffusely infiltrating astrocytoma can be illustrated using my own two personal hands. A circumscribed glioma has a pushing margin that displaces the adjacent neural tissue. As illustrated here, circumscribed gliomas like a pilocytic astrocytoma are commonly biphasic with a solid tumor nodule and a fluid component. Rather than transecting or compromising the white matter tracts, as the lesion expands, it displaces them to the side. Circumscribed and low-grade gliomas occur most commonly in children and young adults. There's a very small chance of transformation to a higher grade tumor, and those tumors are called grade 2 and not grade 1. They don't infiltrate into the surrounding tissue, resection is oftentimes more complete, and they usually enhance, oftentimes with a fluid component. Let's look at some of the circumscribed WHO grade 1 or grade 2 lesions. The most common example we're familiar with is the pilocytic astrocytoma of the cerebellum. In an adult patient in the same location with a similar morphology is the hemangioblastoma, which is not a glioma. Ependymomas within the ventricle are well demarcated and circumscribed, and also the extraventricular hemispheric ependymoma is a circumscribed glioma. The ganglioglioma of the temporal lobe and the cerebral hemispheric pleomorphic xanthoastrocytoma are other examples of circumscribed lesions. When we think about the imaging of astrocytomas, it's important to remember that contrast enhancement is only a bad prognostic sign when we're looking at diffuse gliomas. It is a good prognostic sign when we see it in a grade 1 tumor. The grade 1 tumors have both enhancement and heterogeneity, but the heterogeneity is due to fluid in the low-grade tumors and it's due to necrosis in glioblastoma multiforme. If we compare these two images, we have a pilocytic astrocytoma in the cerebellum that is an irregular heterogeneous ring-enhancing mass. And we also have a glioblastoma multiforme in the frontal lobe. These tumors are differentiated primarily by their histology, but also by their location and their age. And using genetic markers, the pilocytic astrocytoma has a BRAF fusion mutation, and the glioblastoma, as we mentioned before, is likely to have IDH wild type. If we look at the difference between a pilocytic astrocytoma and a glioblastoma, we can see that while both of these lesions enhance, perfusion imaging is typically cool or cold in the nodule in a pilocytic astrocytoma, but it's going to be hot in the solid portions of a glioblastoma multiforme. Let's talk more in detail about circumscribed gliomas. Pilocytic astrocytoma, Pilomyxoid Astrocytoma, the unpronounceable Pleomorphic Xanthoastrocytoma, Subependymal giant cell astrocytoma, and Ganglioglioma. Again, the vast majority of the circumscribed astrocytomas have BRAF mutations, and so this is the molecular marker that we should think about as a differential feature for these tumors. The pilocytic astrocytoma is the poster child for the circumscribed gliomas. These are WHO grade 1 tumors. They primarily occur in the first 2 decades. They're circumscribed, enhancing, and fluid secreting. They most commonly occur in the cerebellum and the diencephalon. As a reminder, the diencephalon is the thalamus, the hypothalamus, the optic nerves chiasm, and the optic radiations. A prototypic pilocytic astrocytoma will be a solitary cerebellar mass. The typical age peak is at about 10 years. The mural nodule may have low attenuation on CT and calcify in up to a quarter of cases. The nodule itself will have increased diffusion and it enhances, but typically without significant increase in perfusion. The wall around the fluid-filled space may or may not show contrast enhancement, but it's easier to recognize when we have the classic cyst and mural nodule appearance. Two examples here of a pilocytic astrocytoma, both in a child. Both have the classic appearance of a nodule and a larger fluid-filled area. Most of the mass effect comes from the fluid and not from the solid portions of the tumor. The nodule secretes the fluid due to leaky capillaries. The same leaky capillaries are what cause the pronounced contrast enhancement, but there is minimal to any neovascularity, and these lesions are typically not going to show a tumor blush on angiography. As a pathologist once told me, when you have a heterogeneous lesion, you must distinguish between fluid and necrosis. The pathologist always told me, fluid is good. Necrosis is bad. And I asked them what they meant. And what they meant was, if you have necrosis, it's typically a high-grade tumor, but almost all of the fluid-producing tumors are going to be WHO circumscribed lesions with a low grade of typically 1, but sometimes 2, and rarely 3. Again, the pilocytic astrocytoma has a pushing margin. We can see here in the DTI image in a cerebral hemispheric pilocytic astrocytoma that the corticospinal tracts are being displaced by the tumor. Not transected, not destroyed, not infiltrated, but merely being displaced. If we look at the same patient, again, we can see the fluid on the coronal MR. The nodule is not visible on this particular plane of section. And after resection of the tumor, the corticospinal tracts return to a more normal location, and there's a residual postoperative cavity. These tumors, again, can be resected completely for cure. The nodule in a pilocytic astrocytoma, as shown here in the photomicrograph, is very well demarcated. As we mentioned earlier, up to 25% will have a calcification within them. The pushing margin is also evident here, and sometimes there is surrounding reactive gliosis. This is a different patient, but we're illustrating here the rim or margin of the fluid-filled space. This is typically not composed of neoplastic tissue. It's composed of compressed cerebellar tissue or sometimes a mild reactive gliosis. Remember that for the pathologist, the definition of a cyst is a fluid-filled space lined by an epithelium. So these are not true cysts. These are fluid-like or cystic lesions. So we have to think about, whenever we describe them, to bring out our air quotes and talk about them as a cystic lesion rather than a real cyst. There are some variants of pilocytic astrocytoma. Sometimes there is a complete rim of enhancement without a nodule. They are rarely solid with no fluid component. Exceptional cases do not show contrast enhancement, and they occur, as mentioned earlier, in supratentorial locations, including in the cerebral hemisphere. This is an atypical pilocytic astrocytoma. The patient was 42 years of age. The calcification in the cerebellum was identified on a screening exam after a car accident. We can see that this lesion has no contrast enhancement and no fluid. Because of uncertainty, it was biopsied, and the biopsy was a pilocytic astrocytoma. It's been suggested that pilocytic astrocytomas grow primarily within the first 2 decades of life, and if the patient makes it to their 20s without having the tumor identified, they may become dormant. And the pathologist described this as a burned out pilocytic astrocytoma. Here's another pilocytic astrocytoma that shows us an arc of enhancement around the outside. It's very irregular. If we look at the left side of the image, we might perhaps think about a glioblastoma multiforme, but the fact that we have fluid that's not rimmed by contrast is a strong indicator that this is fluid being produced rather than necrosis. After all, necrosis is almost always surrounded by living tumor tissue, which is why it's called central necrosis. If we look at the coronal image, which was taken a few minutes after the axial image, we can see a very, very thin rim of enhancement, uniform thickness, and this is enhancing gliosis, not enhancing neoplastic tissue. Here are a couple other examples of pilocytic astrocytomas. The very heterogeneous nature of this ring-enhancing lesion mimics the morphology of a GBM, but again, the posterior fossa location and the age of the patient are inconsistent with a glioblastoma multiforme. Not impossible, but not suggestive of a GBM. We can also use advanced imaging to distinguish between a pilocytic astrocytoma and other enhancing glial tumors. The nodule in a pilocytic astrocytoma contains microcysts and will typically have an elevated ADC and a low attenuation on a CT scan. In contrast, the solid portions of a glioblastoma typically are going to show some decreased ADC because of their high cellularity. And again, as mentioned before, we can use perfusion imaging to see the difference between the nodule of a pilocytic and the enhancing solid portions of a glioblastoma multiforme. Pilocytic astrocytomas, again, have a variety of morphologies. I'm illustrating that they are not always a cyst and mural nodule, and you have to keep this in mind. Again, the BRAF mutation is very common in the circumscribed gliomas, especially those with fluid production. But there are several different types of BRAF mutation. Pilocytic astrocytomas in the posterior fossa typically have a BRAF fusion mutation, whereas the pilocytic astrocytomas that are supratentorial oftentimes have a V600E substitution. I want to show you some diencephalic pilocytic astrocytomas. The most common glioma arising from the hypothalamus and chiasm is a pilocytic astrocytoma. Don't be dissuaded by its unusual location or by its vivid contrast enhancement. The differential diagnosis for this location always begins with pilocytic astrocytoma. Notice the secondary hydrocephalus caused by obstruction of the posterior portion of the third ventricle. Here's another patient that has a hypothalamic mass, but this is not showing any contrast enhancement, and this is the typical appearance for a hypothalamic hamartoma. So the differential diagnosis is very clear when you have a non-enhancing suprasellar mass arising from the hypothalamus. Again, notice that both of these patients are children. In the differential diagnosis of an enhancing primary neoplasm, it's important to consider the patient's age, the tumor location, whether we have rim versus nodular enhancement, and whether we can determine whether we have necrosis versus fluid. We want to remember that the vast majority of fluid-secreting tumors are capable of contrast enhancement. In fact, the vast majority of them actually demonstrate contrast enhancement on CT and MR. The fluid-secreting neoplasms, as we've mentioned before, include Ganglioglioma, Pleomorphic Xanthoastrocytoma, ependymoma, Pilocytic Astrocytoma, and Hemangioblastoma, which is not a glioma. In considering the differential diagnosis for a fluid cerebellar mass, between pilocytic and hemangioblastoma, there are several important differential features. Not only the age of the patient, but also the vascularity of the lesion. Perfusion-weighted imaging is typically not going to be significantly elevated in a pilocytic, but it will be in a hemangioblastoma. In addition, the nodule in a pilocytic astrocytoma is going to have increased diffusion, elevated ADC values. So if we look at this example here, from Dr. Mauricio Castillo, we can see that we have a cold nodule in a pilocytic astrocytoma, and yet the perfusion imaging shows a hot nodule for the hemangioblastoma. But typically the age of the patient has such sufficient differential value that perfusion imaging is not necessary. Let's look at some other low-grade gliomas. Ganglioglioma is a circumscribed tumor of mixed neuronal and glial derivation, WHO grade 1. These patients are typically young adults who present with seizures, perhaps because the most common location is in the temporal lobe. Fluid and calcification are very common, and these are caused by a V600E substitution mutation. A classic example here on CT scanning of a ganglioglioma in the temporal lobe. We can see the fluid component. Sometimes protein in the fluid will increase its attenuation value. We can see on the MR scan that the fluid is not identical to the CSF in the temporal horn of the lateral ventricle. And we can see vivid enhancement of the nodule after gadolinium has been given. Now, this lesion could be a pilocytic astrocytoma or a PXA. There's nothing definitive about this appearance that distinguishes amongst these different fluid-secreting tumors, but they all share in common that they should be resected for cure, and the neurosurgeon should not merely take a biopsy of a lesion with this appearance. So this is a ganglioglioma. The next circumscribed glioma is the pleomorphic Xanthoastrocytoma. PXAs can be grade 2, or they can be an anaplastic PXA, which is a grade 3. It should be noted that some grade 2 PXAs will transform over time to become anaplastic if they are incompletely resected. That's why these lesions are not considered to be grade 1, because they can undergo a progressive transformation. PXAs also have a V600E substitution mutation. That's a good molecular marker, but it is not distinguishing between PXA and some of the other supratentorial fluid-secreting tumors. PXAs may present at all ages, but they are predominantly seen in children and young adults. Typically, the nodule of the PXA is going to be in a more peripheral or subpial location, and they almost invariably show contrast enhancement as illustrated here. Once again, note that the cyst fluid contains protein and is not identical in signal to cerebrospinal fluid. The Pilomyxoid Astrocytoma is another type of fluid-secreting, contrast-enhancing tumor that has a BRAF mutation. This was formerly considered to be a variant of pilocytic astrocytoma, but is now recognized as a separate and distinct entity. The PMAs typically occur in the vicinity of the third ventricle. Oftentimes they have a very heterogeneous appearance, and they have multiple small areas of fluid instead of having a large loculated fluid collection. The appearance is a little bit more ominous, and the behavior of the Pilomyxoid astrocytoma is also much worse than the prognosis that we see in pilocytic astrocytomas. PMAs also may have increased relative cerebral blood flow, especially in comparison to pilocytic astrocytoma, and this can be used as a differential feature preoperatively. Astrocytoma. Subependymal giant cell astrocytomas, again, are circumscribed grade 1 tumors. They predominantly present in young patients in the first 2 or 3 decades of age. The most common location is in the wall of the lateral ventricle attached to the head of the caudate nucleus near the foramen of Monro, where they can cause obstructive hydrocephalus. They usually show contrast enhancement. Greater than 90% of the patients have tuberous sclerosis, and up to 15% of TS patients will develop a subependymal giant cell astrocytoma. It's been discovered over the past 5 years that these patients respond to drugs that are mTOR inhibitors, the mammalian target of rapamycin, and the current best therapy is with everolimus. Everolimus, you may remember, is the same drug that is eluted from coronary artery stents. So the subependymal giant cell astrocytoma, its most typical and characteristic presentation is a relatively larger mass, 1.5 to 2 centimeters in diameter, attached to the caudate nucleus, protruding into the lumen of the ventricle, covered by an intact layer of ependyma, in a patient who also illustrates subependymal nodules, showing that they have tuberous sclerosis. Subependymal giant cell astrocytomas can also be larger. They're circumscribed, they don't infiltrate the brain, and they do not have CSF dissemination. The characteristic location and the companionship with a patient who has tuberous sclerosis can cinch the diagnosis for you. To summarize what we had a chance to talk about in these 2 lectures on intraaxial primary tumors, or gliomas, Most diffuse gliomas have IDH mutations. Oligodendrogliomas have 1p19q co-deletion. Glioblastomas are usually IDH wild type with a very poor prognosis. And we just finished talking about circumscribed gliomas. They're usually grade 1. They have BRAF mutations. They almost always have contrast enhancement, oftentimes with a cyst. And the grade 1 circumscribed tumors don't progress from being a grade 1 tumor into a higher grade lesion. So we should all remember that there are good mutations and there are bad mutations. Let's finish with a couple key points. A mass in the temporal lobe with fluid and a nodule is likely to be a ganglioglioma with a BRAF mutation. A densely calcified lesion in the cerebral hemisphere of an adult is likely to be an oligodendroglioma with a 1p19q co-deletion, and these tumors are also going to be IDH mutated. A heterogeneous enhancing mass in the cerebral hemisphere is likely to be an IDH wild-type glioblastoma multiforme. A nodular lesion with a fluid component in the cerebellar hemisphere in a child is going to be a pilocytic astrocytoma with a BRAF fusion. The T2 flare mismatch sign in a circumscribed cerebral hemispheric lesion is likely to be an IDH mutated astrocytoma grade 2. And an expansile lesion in the pons, especially one in a child or young adult, is likely to be a diffuse intrinsic pontine glioma or midline glioma with a histone H3K27M mutation. Also remember that contrast enhancement is a bad sign for diffuse gliomas, but it is a typical sign in the circumscribed gliomas, and that a heterogeneous tumor can be the result of fluid secretion, which is good, or necrosis, which is bad. Thank you very much for your attention.